basically any type of pathology that involves vessels within the IFU that has a component of acute or subacute thrombus, I think that the Pounce device comes into my algorithm. There's obviously an innumerable amount of possibilities where it might not be, but I would say in 80% of those cases, the Pounce device will likely be beneficial to the technical success of the procedure. So that can be by preoperative imaging, where you have a CAT scan or you have non-invasive studies that show that you have a level of subacute or acute thrombus, or it can be based on the behavior of the wire, or it can be based on IVUS. But once you identify that you have a degree of thrombus, subacute, acute, that could possibly embolize during the procedure, I think that's a good time to think about doing a thrombectomy, and the Pounce device is very well suited to treat it.
I agree. I think, I always approach a case in the cath lab, not just angiographically, but also by what I feel, that, so to speak, interventional exam. So if my wire crosses pretty easily and I'm pretty convinced that there's soft material and I know the patient's history is consistent with something subacute or acute, that really I don't see a downside in pulling the Pounce system and trying to use it as long as the vessel's the appropriate size and I've got good targets.